Good morning, good afternoon, or good evening, everyone. My name is Ikuo Takizawa. I'm a Principal Research Fellow at JICA, Ogata Sadako Research Institute for Peace and Development. And thank you very much for joining today's seminar titled Invisible Gaps, Addressing the Financial Burden of Cancer Care Toward Universal Health Coverage. And we are grateful and excited and seeing that a big turnout. I think people are still joining. We are counting, but I think we'll start now. So before we start today's seminar, I would like to give a housekeeping announcement to everyone who is attending online. But please turn off your microphone when participating. And today's seminar will be recorded for future reference. And after this session, we will take some of the questions from the audience and move directly to the question and answer session. So during the talk session, please send your questions to the panelists using the Q&A button at the bottom of your screen. And due to time limitations, we may not be able to answer all the questions, but we'll try our best. So a little bit of introduction. JICA Ogata Research Institute holds a seminar like this for the purpose of sharing the latest knowledge around development issues and providing networking opportunities. And today we are focusing on the financial burden of cancer care in low and middle income countries from the perspective of universal health coverage. As we know, the cancer is becoming one of the major public health challenges, even in low and middle income countries, yet the patients and their families are struggling to get appropriate care in often fragmented health systems. And also, cancer is a huge economic burden as it requires repeated care in highly specialized hospitals located only in major cities, inflicting significant impact on the patient and their household. And we have three excellent presenters to shed light on the harsh realities. First, we have Dr. Akiko Ida. She is the visiting research fellow of our institute, as well as the associate professor at Shimane University, Japan. And she will give us an overview of the issue, as well as some economic burden cancer, specifically in Africa, based on her research work at our institute. Welcome, Dr. Ida. And then second, we have Dr. Beverley Essue. She is the associate professor, Dalla, Lana School of Public Health, University of Toronto. And thank you for joining Dr. Essue for this session from Canada. And she will provide global picture and the magnitude of the issues, as well as some methodological challenges for the measurement. I suppose many of the audience, particularly from JICA, are familiar with the indicators such as catastrophic and impoverishing health expenditure as a measurement for economic burden of healthcare. But other measures such as subjective evaluation of economic hardship and distress are also important. And I hope she can help us broaden our understanding of how we can capture the economic burden of healthcare, particularly the cancer care, comprehensively. And then we have Dr. David Watkins. He's the Associate Professor, Faculty of Global Health at University of Washington. And thank you, Dr. Watkins, for joining us from the United States. Which is the focus of attention in global health in many ways today. And I try not to go too deep into that topic because it takes an entire day and evening. And he will enlighten us with the methodological innovation in incorporating financial burden data into prioritization exercise of health services through application of extended cost effectiveness and analysis. Again, many of the audience might be familiar with cost-effective analysis application in health using such measures as DALIs and QALYs. And I myself studied at Harvard School of Public Health in the 1990s when Professor Chris Murray was still there. So, and it was the World Development Report in 1993, the Investing in Health by the World Bank, which mainstreamed cost-effective analysis in global health to come up with the best buys or a bundle of health services which are considered most cost-effective and suitable under the resource constraints. But measuring effectiveness only with the improvement in health status may not be adequate, particularly when you apply UHC lens, where financial protection is another important pillar of health systems. So if you incorporate impact on financial protection in cost-effective analysis through the use of extended cost-effective analysis, how will the prioritization change and what implication does it have in cancer care? So we're expecting to hear more from Dr. Watkins. And then after three presentations, we'll invite Mr. Tomoya Yoshida as a commentator. Mr. Yoshida is a Senior Deputy Director General of Human Development Department of JICA. He is supervising JICA's NCD-related operations. And thank you, Mr. Yoshida, for joining as well. So I believe today's seminar will be thought-provoking and quite relevant for our own work at JICA, as well as everybody joining this seminar online. So without much ado, I would like to invite the first presenter, Dr. Aida. So Dr. Aida, please take the floor.
I'm presenting the challenge of the cancer epidemic in low and middle income countries, social and financial implications on the ground. My message today is that cancer is a poverty issue, and I'd like to give some evidence, although they are quite limited, based on our research on Africa. So let us start with the situational analysis. By 2030, evidence suggests that 3/4 of cancer deaths will occur in low and middle income countries. Several factors have been identified. Cancer-related infections, particularly in Africa, population growth, aging, and unhealthy lifestyles. People tend to sit down and not to be very active. Also, we don't know much about the realities based on the evidence yet, but we know that there are environmental pollutions, especially air pollution and environmental destructions, and lack of access to cancer care is also a factor contributing to more deaths due to cancer. We have a lot of technological advancement for the past 2 decades globally. However, many countries, especially low and middle income countries, have not benefited from those technologies. Cancer-related research today heavily concentrates on rich countries, especially the United States. And I'll talk about African situation later, but we have a lot of challenges to understand what is going on the ground. Late diagnosis is a major leading factor to high mortality, and I'll talk about that later. And the most important subject today is the financial burden, which is also rising, while cancer deaths and cancer patients' cancer incidence are on the rise. Next slide, please. The average life expectancy in low and middle income countries is just around 63 years old. So I'm presenting cancer incidence under 65 to correspond with the life expectancy. We see that there are a surge of cancer incidence coming, although richer countries have more incidence. We have to be mindful that poorer countries have less evidence. We have very limited number of research and studies done on those countries. Next slide, please. When we look at region by region, Asia takes up more than half of the incidence. We have to be mindful that regions do not mean that all the countries in Asia region, for instance, are poor country. However, this is a kind of indication where cancer patients are. So Asia, Africa, and Latin America, when we combine those regions, we see that 72% of the world cancer incidence are concentrating in those areas. Next slide, please. So this is the mortality rates under 65 in low and middle income countries. We notice that in sub-Saharan African countries have very high mortality rates. Also, Southeast Asian countries. We also look at Latin Americas. So there's a quite unequal situation in terms of getting care and survive. We have a very huge challenge when we look at these high mortality rates. Next slide, please. So based on this situation, our team decided to study on the financial burden of cancer care in sub-Saharan Africa, because Africa has been, well, among low and middle income countries, Africa has been heavily impacted by cancer incidence and mortality. However, we don't know so much about financial burden in this region. We conducted two types of research. One is a systematic review on financial toxicity of cancer care in sub-Saharan Africa. Our protocol is already available online. If you're interested, please have a look. The second one is a qualitative research on access to cancer care for children in Burkina Faso. And I'm going to present relevant results in this presentation that follows. Next slide, please. Based on the systematic review, we find very high financial toxicity. By the way, financial toxicity, this term is relatively new to public health domain, and later Professor Essue will talk about major concepts on financial burden related to cancer care, and this is also related to her presentation. Financial toxicity covers both direct costs, indirect costs, and psychosocial costs. So we included psychological stress in addition to financial actual monetary and material burden. So when we look at sub-Saharan Africa, we found that there's a very high level of financial burden of cancer care. But before starting to talk about the results, we noticed that studies are concentrating in 5 upper, middle, and high-income countries, where you can look at the map. Nigeria, Kenya, and South Africa, Ethiopia, Ghana. And those countries are the major ones which are producing evidence so far, but we don't know much about the other countries. So we have to note that among low and middle income countries, or even within sub-Saharan Africa, there are inequalities in terms of evidence. To know what is going on the ground. About the actual financial burden, it is difficult to compare all the countries, but we know that the very high catastrophic health expenditures recorded. For instance, in Nigeria, Knapp et al. Recorded between 86 and 95% of households experienced catastrophic health expenditures, meaning each household is spending more than 10%, between 10% and 20% of their household income to cancer care. People have been paying for their treatment, transport, and other expenses out of their own pockets. There are limited support from the government or other sources. This is, they have been paying between $57 and $5,306 in US dollars. Well, this is quite a huge range, and you may wonder what this really means. Well, there are different way of measuring out-of-pocket expenses. So some studies measured how much patients and their family paid for the first month after the diagnosis, and other studies measured the entire cost that were incurred for that cancer treatment. So there's a wide range here. Next slide, please. Such financial burden leads to adverse consequences, obviously. First comes the loss of income and assets. People are selling their house, using their savings, and in an unsustainable manner. The consequence is a low quality of life for the patient, but also their family members. Children can no longer go to school, or people have to have double work, etc. Less access to treatment is another important consequence. So people who do not have money decide not to go for doctor appointments. This leads to less optimistic prognosis and higher mortality. Important psychological consequences are also recorded. People worry so much about their own financial situation and also the consequences for their family in particular. Many people fear death because they are not getting necessary health care. And low self-esteem because sometimes, especially women, were pointed out as money drainer in the family, affecting other members of the family. Africa is known for a place for a very high rates of cervical cancer. Women often lost spouse, and due to their own financial situation, husbands told the wife that he can no longer support her and she should stop treating herself, etc. And there's a serious situation related to family breakdowns. People feel awkward participating in social activities. People become lonely and isolated. Next slide, please. People are not affected in the same way, especially low-income households. Households with more family members, large households, people who live in rural areas because they have to travel a long distance to get to hospitals in the capital area, patients with disabilities and in advanced stages, well, they can no longer work and get income in a regular manner. Patients and family with physically demanding jobs are also more affected than others. For instance, teachers were less affected because they could continue teaching while they're being treated. But people in Africa, many of them are engaged in agriculture and they have a lot of challenges. We have to take into consideration that such inequalities affecting the vulnerable social groups. And this has also much to do with universal health coverage framework that I'm going to mention later. The next slide, please. I'd like to quote one testimony from a father of 45 who I met in Burkina Faso while I was doing a qualitative study. He agreed to appear on this slide because there are a lot of discriminations against cancer patients and their family in the country. We decided not to show his face. As you know, in Burkina Faso, there are armed conflicts ongoing, and he had to be displaced from his village in the north 2 years before the interview took place. So he had to flee with 11 members of his family. The entire family moved to his friend's house in the urban area. One of his sons, today he is 3 years old, got cancer, sarcoma, a kind of a tumor in the arm, and he had to be treated. In the interview, he said, "I am displaced. I even don't have a place to sleep in Ouagadougou while my son is treated." Actually, he has been sleeping in a small space in the hospital. A doctor asked me if I had money, and I said no. Then she gave me a ride to another hospital herself. He borrowed money from his friends because he has been out of job for 2 years. But he was very serious about his son's illness. He didn't know, and today he even doesn't know that his son got cancer. There was a communication barrier in terms of the language. He did not quite understand what the doctor was saying. But he borrowed money, and went to 5 different hospitals in vain. Fortunately, today his son has been treated in a specialized hospital in the capital. So this is one example that there are many people in a vulnerable situation also getting cancer and having extra obstacles to get treated. Actually, in Burkina Faso, also there are standard treatment available, although it is quite limited. His son had an opportunity to be treated, but to get to the hospital was a long way. The next slide, please. So this is the analysis that we made. Cancer brings a vicious circle to Africa, which has been already overburdened with other poverty-related issues. In Africa, more than 40% of people live under the poverty line. More than 60% of people are engaged in agriculture, which is not a bad thing, but this physically demanding job, when it is combined with cancer care, it is quite creates a difficult situation for the patient. Also, health systems are quite fragmented and not fully functioning. It's not only that cancer care is not available, but the ordinary care or just getting to the hospital is a challenge. So this is the precondition. And in addition, cancer requires a lot of things in addition. So cancer requires treatment on a long term. However, so far, external assistance and health insurance are quite limited. Health insurance in some countries are available. For instance, in Sudan, in one hospital, we found that more than 50% were covered with some sort of health insurance. However, this insurance did not cover most of the needs in terms of medical care, transport, and lodging, etc., while the patient and the family are visiting the hospital. Africa accounts for 23% of global cervical cancer mortality. Actually, many women in Africa get cervical cancer, and their mortality is also very high. So in this situation, women often get disabilities, and they continue to get treated and try to survive. However, their disabilities become another challenge. So the combination of pre-existing poverty and weak health systems combined with the demands of cancer care and other conditions lead to more impoverishment of cancer patients' households and also less optimistic prognosis. Next slide, please. So this is the famous universal health coverage cube that WHO has been advocating and we have been supporting. When we think about these situations of cancer patients and their family members in Africa and elsewhere, this is not an acceptable situation. If we consider the concept of universal health coverage, everybody should be able to access necessary care without excessive expenses. This is not happening here, and cancer has not been considered as part of this framework, unfortunately. The next slide, please. So the final slide, takeaway messages. Today, cancer crisis in low and middle income countries is real, and it is leading to increased mortality, poverty, and inequalities. I have to emphasize that the poverty and inequalities, because we have not paid enough attention to that. My recommendation is to include cancer in UHC efforts that we have been putting a lot of efforts and support. We need financial mechanisms to deliver essential care, including cancer care, and to protect cancer patients. I'm not just emphasizing on cancer care and cancer patients, but they need to be integrated to the current efforts. We need to strengthen health systems. For instance, when patients go to CT scan or MRI to get their medical exams, often machines may not be available. Even insured drugs may not be available. So such situations is not particular to cancer care, but those are the issues related to health systems. And we need to strengthen the systems so that not only cancer care or cancer patients benefit from those, but the entire sick people can get healthier. We also need to listen to voices of patients and families. We tend to ignore the details, but for instance, the family in Burkina Faso that we have been studying, we have to pay attention to the vulnerabilities that are created in the specific situations of the country, such as armed conflicts and displacement. Final but not least, more research is needed for low-income countries. We know a lot about how high-income countries like the United States and Japan, but we have very limited evidence so that health policy can be made based on such evidence, and cancer can be integrated in routine health policy making process. The next slide, please. Thank you very much for your attention, and I'm very grateful for the internet connection. Thank you.
Thank you very much, Dr. Ida, for a nice presentation, and particularly shedding some light on the hard realities of people and the patients and families that are going through to obtain the care needed, and as well as the very hard challenges like financial as well as socioeconomic challenges. Thank you. Through your work applying the anthropological and also ethnographic methodology. Thank you very much. By the way, we are counting like over 100 people are joining online. We are very grateful for the large turnout. And if you have a specific question addressed to Dr. Ida, please indicate that when you type in your question in the Q&A. So now I'd like to invite Dr. Essue for her presentation. So floor is yours.
All right. So good morning, good afternoon, good evening. Thank you very much for the opportunity to join you today on this webinar on quite an important topic that I have spent quite a bit of my career thinking about and researching, and I really welcome the opportunity to share some reflections on the methods and the concentration of research and what I see as sort of opportunities in this context. So my name is Beverley Essue. I am an associate professor of global health systems based at the Institute for Health Policy Management and Evaluation in the University of Toronto. In the time that I have with you today, there's a couple areas that I want to cover, and I'm delighted to follow Dr. Ida because she's set up this transition to focus on the methods quite nicely. So I'm going to give some background thinking about this concept of financial protection in the context of cancer and provide some background and definitions. I want to very briefly and very selectively address some of the evidence on gaps in financial protection, and then spend a little bit of time thinking about approaches to measurement and what we see as some of the opportunities to move things forward. So, you know, I don't think I need to necessarily spend as much time here because I think that Dr. Ida set us up very nicely to understand the concept and the challenge that we have ahead that is not a new problem. It's not a new problem facing health systems. I think we have for a very long time understood and built health systems to have an ongoing reliance on private expenditure in the form of out-of-pocket costs to pay for healthcare, not just cancer care, but healthcare more generally. And we, for several decades, have measured and understood that this reliance on user fees creates a financial barrier to access. And there's many, many barriers to access, some of which were reflected in the previous presentation, but in particular, the out-of-pocket costs pose an unnecessary financial barrier that doesn't only limit access to unnecessary care, which is what it was originally conceived to address. It also limits access to necessary care. And so that creates a problem in the context of needing access to essential care. Quite old estimates now, and I believe that there's work to have updated these, but I reflect them because I think they're most familiar to all of us, have estimated that at least 150 million people a year face this concept of financial catastrophe, this idea that you face a level of health expenditure or expenditure on healthcare that exceeds one's affordability. And we'll come to how that's defined in a minute. And over 100 million individuals are driven into poverty, but because of this expenditure. And so that's a problem. And that links very directly to the proposition that Dr. Ida put forward in terms of conceiving this not just as a healthcare issue, but importantly as a poverty issue. So the challenge with non-communicable diseases is that they contribute to this economic burden on households in very particular ways, particularly in low and middle income countries, where there is an aging population that is faced with dealing with a double disease burden of communicable and non-communicable diseases, while also trying to strengthen health systems to meet the demands of unfinished agendas for communicable diseases at a time where the aging of the population is creating this challenge. We know that non-communicable diseases, including cancer, create these repeated and lifelong costs associated with the management and treatment right in through survivorship. And also at the same time, there is inadequate coverage of essential services within developing systems. And so the concept of financial risk protection is concerned with safeguarding people against financial hardship associated with paying for health services. It implicitly involves protection against the financial uncertainty associated with the need to use health services and to pay for them. We've just been reacquainted. We probably have this very intimate in our minds, the UHC cube. And, despite all of the criticisms about it, I think it is still quite an important way to conceptualize what we're striving for and what the kind of goal is in terms of expanding coverage of a breadth of services that address the population health needs of a given population while minimizing to the lowest extent possible the cost sharing responsibility. And so when we talk about financial protection, what we're referring to is this dimension at the top that has the red arrow there signified. And the case for financial protection really kind of magnifies and nicely highlights the interconnectedness of many of the sustainable development goals. So while financial protection as a goal of universal health coverage is positioned within goal number 3, which is focused on good health and well-being, we know that it's intimately linked to efforts to address poverty, efforts to address inequalities. And it is not such a far stretch to also understand the importance of financial protection in addressing access to other essential needs. So goals around hunger, goals around decent work, economic development, and gender inequality, which was nicely highlighted in the last presentation. So in the context of cancer, there's been work that has been increasing over the last decade and a half to really try to understand in a focused way what the challenge and opportunity are for cancer. Quite important work was done in a region close to yours, the Asian region, which is the Association of the Southeast Asian Nations. And this study was called the Action Study. And it led work to quantify for the first time the extent of financial protection for cancer in the selection of countries that were studied. And what they found was that about 50% of households affected by cancer in that region experienced catastrophic out-of-pocket expenditures, which led to impoverishment, and that this occurred within the first year of diagnosis, and that immediate stage when treatment is onset, and at the same time that individuals, households are also most likely to not be able to continue with work. Even with varying levels of universal health coverage, policies and programs advanced within these countries, patients with cancers may not be fully protected. And I've just pulled out a selection of other countries that show that quite high rates of catastrophic health expenditure, which is a measure of inadequate financial protection, are highlighted across a range of countries, and even work within Japan has shown that 63% of patients undergoing chemotherapy reported financial toxicity. So this impact of the cost of cancer care. So what's driving these costs? And so I think it's helpful just to sort of level set, and I find this framework simplistic, but also helpful to understand how the costs can accumulate and what we're talking about in terms of the costs that are contributing. And so many of you will be familiar with conceptualizing costs associated with access to healthcare, described as direct costs, indirect costs, and psychosocial costs. And so here, direct costs are referring to expenses, including time costs for patients when accessing medical care, such as hospital visits, medications, treatments. It's the direct cost that you might pay out of pocket to access care. And the time cost piece is important here because some care is provided unpaid, and so that this conceptualization allows one to capture that. The indirect costs capture the loss of income and productivity due to illness, and that can be from the individual who's seeking care, as well as from any caregivers who have to step away from work in order to take on caregiving responsibilities. And then the psychosocial costs are sort of more often seen as intangible and harder or inconsistently measured. They're getting to the emotional, mental, and social burden of cancer, such as anxiety, depression, and the impact on family relationships that can be a direct result of a heavy burden of experiencing costs associated with care. And so the factors that impact financial protection most immediately in our minds, we think about out-of-pocket costs, but it is also related to this loss of income due to illness. And to the extent that we can measure and cost the psychosocial costs of cancer, the psychosocial costs can also drive additional health service use. They can reduce work capacity, they can compound financial strain, and they can further weaken financial protection. And so if we think about this range of costs, then I want you to remember this when we then go to how we kind of conventionally measure it, which is what I'll spend a little bit of time speaking to right now. So the monitoring and evaluation framework for universal health coverage and for the SDGs has focused quite specifically on two indicators of financial protection, and those include catastrophic health expenditure and medical impoverishment. So these are interrelated concepts, but distinct. So conceptually, catastrophic health expenditure is a measure of the burden of health care expenditure, so out-of-pocket costs. And I'll in a minute come to the fact that different studies include different categories of cost in there. But for now, it's the amount that is spent out of pocket as a share of a household's available resources. And so it can result from sizable and unpredictable one-off payments, as well as from a steady flow of unbudgeted medical expenses that can happen over X period of time that one is dealing with an illness, including relatively small payments, which is often what we see with in the case of non-communicable diseases. Impoverishing health expenditure is defined as expenditure on healthcare that results in a household falling below the prevailing poverty line or deepening its impoverishment if already poor. And so I think a challenge in this field is that there's been a lack of consensus on the definition of what constitutes a catastrophic level of expenditure. The World Bank and the WHO have led approaches for many years, and there has converged with some consistency around the approach to measure it. And what we've seen is that the approach sort of sits into these areas that are described here. So the first is to measure catastrophic health expenditure through a budget share. And the budget share has ranged between 10 to 40% of a household's resources. And that is somewhat context dependent in terms of the upper bound of that threshold. In terms of household resources, there is variation in the literature in terms of what's used to measure household resources. Where income is available, and often income is only available, that is used. Capacity to pay speaks to the amount of income that is left over after we take out essential expenses related to housing and food. So this idea of disposable income for a household. In some cases, the household resources are measured as a share of expenditure. And that's typically where they've used expenditure surveys to measure catastrophic health expenditure, and then disposable income. And so typically we're measuring, when we're measuring catastrophic health expenditure, we want to understand what is the total amount that's spent out of pocket, and the budget share is the amount that reflects as a proportion of the household resources. And then we want to understand how many in a population or in the sample that we're looking at actually experience this incidence of catastrophic health expenditure. There is some move in the literature to measure this concept of catastrophic overshoot, which says that if there is a threshold that's defined for a catastrophic level, what proportion of expenditure exceeds that level? And you see that used also consistently as well. For medical impoverishment, as I mentioned before, is trying to understand the level of expenditure that might push a household below the poverty line. And the poverty line that is used in the literature varies. I think the challenge with this particular metric is that there are certainly the cases where households are already living in poverty. And so any level of expenditure in that case is impoverished. It's further impoverishing. And that's what's highlighted by the hashed area of the slide there. And so the area that intersects in C is trying to show that it is possible that if for some households, they are experiencing a catastrophic level of expenditure that is also impoverishing for that household. But it is also the case that one could spend an unaffordable level of healthcare costs that does not impoverish the household, which is that part of A that doesn't intersect with B and C. So these are the two metrics that are commonly used within the literature, and they are used more frequently as well because they've been identified as part of the monitoring framework for UHC and for the SCG. So they support some comparability when we're using them. So hold on, I think I have. Okay, so what I want to show now is just a very brief overview of the sort of state of the literature. And I think this is a good follow-on from what we've just previously heard. So as part of an umbrella review that we're doing for the Lancet Commission on Cancer and Health Systems, we looked at the literature on cancer costs. And this map here is showing a coverage of studies that have measured cancer costs. And what you see is that the concentration of the evidence is concentrated in high-income countries. They dominate the literature, with a growth in studies in middle-income countries and very few in high-income countries. I want you to recall how this contrasts with what we heard from Dr. Ida in that over 72% of the cancer incidence is concentrated in Asia, Africa, and America, which are the cost of cancer in those contexts are not as well studied, despite the burden. And so that's problematic for our understanding. That's problematic for our ability to make a case to actually address financial protection. In the literature, what we find is that the studies that are measuring costs really focus quite specifically on the direct medical costs. We see certainly evidence of understanding and measurement of indirect costs in terms of productivity losses. Fewer studies are focusing on a broader concept of economic burden or on including non-medical costs. So a lot of that rich information that we heard in some of the qualitative interviews that were in the previous presentation don't necessarily feature in the conventional approaches to measurement. We did a review a couple years ago of studies that have measured out-of-pocket costs. And this slide here is showing among the studies in both low, middle, and high-income countries, what the percentage of annual income that was spent on out-of-pocket costs. You see the green bars are highlighting low and middle-income countries, and the blue bars are high-income countries. And so you go across the bottom of the x-axis, you see higher levels of the share of annual income that is spent on out-of-pocket costs for cancer in low and middle income countries, with this one study from India that sits as an extreme outlier. And when we looked at the weighted average, which is at the far right of this slide, LMICs had a weighted average of 42% of annual income spent on cancer costs on average across the studies. And For high-income countries, it was 16. And I will say that it's fairly daunting. We pulled the U.S. studies out. This number here does not include the U.S. studies. So out-of-pocket costs as a share of annual income is a problem. The purpose of this slide is not to go through all of the studies and to see each of them. What I want to show you in this particular slide is that we did a review to look at catastrophic health expenditure in low and middle income countries across studies in non-communicable diseases. So what I want you to focus on are just the black bands. Those are the cancer studies in this overall review. And what we see is that the level of catastrophic health expenditure across these studies, across regions, ranges from between 20% of the sample reporting catastrophic health expenditure to as high as 70% in the Asian region and in the study in Iran. And that review is several years old. It was done in 2018. I've just pulled this study to show that in this more recent study that was published in 2022, this was done it's a single country study in India for colorectal cancer. 90% of households were subject to catastrophic health expenditure within the first 6 months of a new treatment plan. And so it is still the case that this high treatment burden from costs is relevant. So how large is this issue? I indicated previously that about 150 million households face catastrophic health expenditure each year. And in work that we did for the Disease Control Priorities initiative several years ago, we modeled what that looks like in terms of the number of cases of catastrophic health expenditure for non-communicable diseases. And I won't go through this in detail. I just want to highlight here that in the red band, you see cancer. And so renal diseases stood out as responsible for the greatest number of cases of CHE. And relatively speaking, cancer was among the lower, but still reflecting, I just have it written here, 14 million, 14 million cases. And so part of the sort of cancer as a relatively lower number of cases is a product in part of a lack of services. The opportunity to incur catastrophic health expenditure is directly related to having access to services. And we've heard previously that there is a lack of services available in low and middle income countries. And so that opportunity to pay for care means that we're picking up sort of fewer individuals who have had that opportunity to incur costs. And so we need population coverage for a breadth of services that align to population health needs, including cancer. So when illness occurs in households, its costs don't fall on ill individuals alone. It's the households that make decisions regarding healthcare choices and the allocation of time and financial resources to treatment. Sickness of one member affects the time use of healthy members and influences household decisions regarding the allocation of financial resources. So criticism of catastrophic health expenditure and medical impoverishment has been that they're too narrowly focused on out-of-pocket costs and don't capture the full economic impact of ill health that is relevant for understanding financial protection within a health system context. And so what we've seen in the literature, and we're certainly seeing that in the umbrella review, is that there has been an ad hoc approach to incorporating other measures and outcomes to try to capture some of these other broader understandings of financial protection. Financial toxicity here was shown in the work that was done by Dr. Ada, and it's really speaking to understanding that undergoing cancer treatment can cause these deleterious effects on households. It can impact the financial security and the financial well-being of a household, and it's related to the amount that is spent, but it's trying to capture some of the psychological impacts and the concepts of financial well-being for households. And so that's commonly used in the cancer literature. Economic hardship is trying to understand the trade-offs that happen within a household in making decisions about paying for care. And so in choosing to pay for care, what is foregone as a result of that? And what are the coping strategies of the distress financing that households will draw on in order to be able to manage their care? We've talked about productivity losses, trying to understand what the impact is on lost work and the ability to return to work. And then quite importantly, what is the impact on cost-related non-adherence? So this ability to be able to, are you foregoing treatment or delaying treatment as a result, or ending treatment early as a result of those costs? And the work from the action study shed important light on that too. And so what we see across common features of the studies is that their approach typically uses cross-sectional measurement. There's typically a focus on direct medical costs. There's inconsistency in the cost categories that are used and inconsistency in the tools. Where I just wanted to highlight, and I'm not going to spend a lot of time here, I'm about to wrap up. I want to highlight for the audience that there are a range of approaches that are used where we're collecting this information directly from patients, which is typically the case because of an inability to have administrative data in a lot of settings to collect this. Cost diaries are a very common method that are given within the context of the study, and households are asked to complete them over a 1 week or 2 week period to document all costs and to use that information as a way to maximize the recall of those costs. In the context of cross-sectional studies, individuals are asked to account over X period of time, typically 3 months, 6 months, even 1 year, how much is spent on a range of cost categories. And I mentioned before that there's a large variability in the categories of costs that are included. And you try to be as comprehensive in the breadth, particularly as they relate to the range of costs that households can experience for cancer treatment. Economic hardship, there's this set of questions that we've used in a lot of our research to understand what are some of the trade-offs that households use or households are engaging in order to afford care. And these are contextualized based on the context in which the study takes place to try to understand what else is not being paid for as a result of paying for care. And linked to this, in order to be able to pay for care, what are you doing? Are you borrowing money? Are you drawing down savings? Are you using community loans? How do individuals draw on these resources, and what impact does that have on additional resources? Financial toxicity now has an established tool, and that has been validated in, I think, over 40 countries now. And it is often used alongside measurement of catastrophic health expenditure to get to that economic well-being concept. So to end, I just want to highlight that, even though the literature highlights that there has been an inconsistent approach to the measurement of financial protection, what has happened is that there has been a real growth in the concentration of research, albeit in particular areas. And there's been a lot of thinking around how to advance and innovate on some of the measurement opportunities. And I just want to reflect to end this presentation on a couple of those. The first is that across all of these studies, there are core concepts that are being measured. And so this work that's come out of St. Jude's, that's focused in pediatric cancer populations, is trying to understand what are those core concepts, and can we move towards developing a more consistent tool that can be used across pediatric cancer populations with a strong relevance for its application to adult populations. We're seeing opportunities to leverage existing data that are available. So household expenditure surveys, living standard surveys are being linked with cancer registries, which provide opportunities to not rely on cross-sectional data, to actually use some of the data that are available to be able to examine, track, and monitor financial protection over time. There's also greater awareness. So there's right now at least four cancer commissions in play that have some focus on financial protection that is associated with cancer care, that are highlighting the issue and trying to innovate and push forward methodology. And David's going to speak to that in a minute. And the last thing I'll say is that we're trying to move towards greater quality and consistency in learning, and thinking about how do we move towards a community of practice to better link some of the research that is happening in this space. With that, I will end. Thank you.
Thank you, Dr. Essue, for very comprehensive and very insightful presentations, and particularly focusing on some of the important concepts and definitions, as well as the current status of available data and how limited they are, and then some of the methodologies and then the methodological innovations as well. I think there are a couple of questions coming addressed specifically to you in the Q&A as well as chat box. So if you can think about the response, I think we appreciate it. So I'd like to invite Dr. Watkins for your presentation. The floor is yours.
Thanks very much. It's a pleasure to present some of this work to this group. It's work that, as Dr. Essue was mentioning a minute ago, stems from the Lancet Commission on Cancer and Health Systems. And Bev and I are co-chairing the economics working group for that commission. And so we've been on a journey for the past couple of years of trying to better flesh out ways of thinking about financial protection in cancer integrated into economic evaluation using the approach that was mentioned earlier called extended cost effectiveness analysis. So I'll not spend a lot of time on math and very specific details, but give you a general flavor of the sort of stuff that we're doing right now for this commission and more generally for our work on financial protection related modeling. So as we talked about earlier, a lot of you are familiar with the idea of cost effectiveness analysis, and the standard approach in thinking about cost effectiveness is to look at how much health can you gain per amount of money spent. And there are a lot of methods, standards for doing that. And most of this focuses on appraising new health interventions, new health technologies, sort of one at a time. This is what cost effectiveness analysis does very effectively in many countries. But there's a disconnect between cost effectiveness analysis as practiced in high income countries and the need to build health systems in low and middle income countries. And so many of you are familiar with the WHO's framework for health systems. It's one of many frameworks that you could think about. But I point out here that the goals of health systems, according to WHO and others, are one, to improve the level of health or the health overall. And this is what conventional cost effectiveness analysis focuses on. But there are other goals as well, including equity, the distribution of health in the population, and including financial risk protection. And those goals are quite important to think about in the context of universal health coverage, because universal health coverage is not just about better health, but it's about better health for all with financial protection. And so what extended CEA does is try to answer address these other outcomes that are important in health systems, but have been not a key part of cost effectiveness analysis to date. Now, this is pretty obvious if you work in health benefits packages. For example, if you're working for an insurance agency in a country, a lot of what you care about is providing financial protection. That's what insurance systems are meant to do, is prevent people from out-of-pocket costs. But there's been a disconnect between the people who think about cost effectiveness, analysis, and the people who think about insurance design. We propose, and the WHO proposed a way to kind of bring these things together by developing a consensus-based process for including interventions in health benefits packages. And they propose three basic criteria that countries should consider. One is that those interventions provide very good value for money, so they're cost effective. Two, that interventions that are in health benefits packages are also interventions that promote equity. They prioritize the worst off. And three, that they provide financial protection as well. Now, of course, cost effectiveness or value for money is the main thing to consider in benefits packages, because when you use public money to purchase services, you should be focusing on the best use of that money. But equity and financial protection are also key criteria for designing benefits packages. And so, when you think about designing a benefits package, you would have sort of financing directed towards interventions that are of highest priority. And so those interventions would be fully prepaid. But other interventions could be offered through a system, but with cost-sharing arrangements. Importantly, WHO does note that some interventions need to be financed by out-of-pocket means, and those interventions would be the ones that provide very low value for money or do not pass these other criteria. And so they recognize, as all countries recognize, that we can't do everything, that UHC isn't about providing everything for everybody, because no country can do that. It's about providing essential services that are needed by the population and are high priority with full prepayment. Now, we've seen this cube several times during this presentation, and I'll come back to it a couple of times as we think about extended CEA. Another way of thinking about the challenge of extended CEA is that, most of the time we think about the dimension of what sorts of interventions can you include in a benefit package, right? What sorts of things are cost effective? And this is what cost effectiveness people focus on. But in the UHC cube, there's also the question of how do you, reach all the people in a population? This is sort of what implementation or maybe equity-oriented researchers and practitioners focus on. And then there's the question of prepayment. So, there's financial protection people who think about how do you design policies that, reduce out-of-pocket costs. What we try to do with extended CA is have an integrated approach to priority setting and health benefits packages that pulls these three criteria together within one analytic framework. And so that's really what extended CA tries to do. And this is a schematic. If you want to get more information on the methods behind extended CEA and the math, I would recommend this primer by Stefan Berger, our colleague at Harvard, who developed this method. And basically, the idea is that you would do your conventional cost effectiveness analysis, but look specifically at the flows of funds, out-of-pocket funds, and disaggregate a bit from, purchaser costs. And importantly, to track how those out-of-pocket costs might change with public finance. And that gets into the question of financial protection. But you would also look, ideally, at disaggregating this by whatever equity-related dimensions you care about. Professor Berger says, we could try to do something with wealth quintiles from the poorest to the richest. You could also think about doing disaggregation by gender or by province or state in a country, or whatever relevant dimensions of equity are meaningful in your context. But the canonical extended CA approach is to look at wealth quintiles or income quintiles as the way of thinking about equity impacts. And the way we present this information is usually to look at, the amount of financial protection provided relative to the amount of health provided by an intervention, and look at that impact in different wealth quintiles from, poorest to richest. And you can get a sense, and this is for rotavirus vaccine, what a equity gradient might look like and what sorts of financial protection you might get relative to a level of health for a given intervention. But the most interesting application of extended CEA, at least as far as I can think of, is when you begin to look at a lot of different interventions across the whole healthcare landscape. So this was a paper looking at 9 interventions in Ethiopia. It's just an illustrative kind of hypothetical study looking at these 9 interventions. And if you were to do full public finance of these interventions, and offer them in the population, scale them up, per $100,000 spent, how many deaths could you prevent? So that's getting to cost effectiveness. And then per $100,000 spent, how much could you reduce medical impoverishment by public finance of those interventions? And so that's what's seen here on the y-axis. Now, what's interesting is that you have some interventions that do very well on cost effectiveness, like measles vaccine, pneumococcal vaccine. But in terms of financial protection, they don't provide very much. They do prevent illness, but those illnesses are usually not terribly catastrophic in terms of out-of-pocket spending. But there are other things up here that maybe don't provide much in terms of value for money in health terms, but provide a lot of financial protection. So hypertension treatment and preventing people spending on heart attacks and strokes, tuberculosis treatment, moderately cost effective, but very high on financial protection because of the high cost of treatment. And so you get these interesting trade-offs between interventions that are really cost effective but don't provide much financial protection, and interventions that provide a lot of financial protection but don't provide as much on health. And how do you decide those things? Well, this is an issue for policymakers to deliberate. But the point of extended CEA is to show these trade-offs so that planners can sort of deliberate which interventions they would want to prioritize. Now, implicitly, there's some weights, preference weights and things like that would be part of this decision process. And so we have some work ongoing right now to try to quantify how much policymakers prioritize health versus financial protection using discrete choice experiments. But this is stuff that's an empirical area for research. But the point is, whatever your indifference curve is on this plot, you would be able to identify interventions on that frontier that are satisfactory on either health or financial protection. Now, what does this all mean for cancer? This is the subject of this webinar. So we've applied the extended cost effectiveness analysis method to cancer systems and looking at a range of cancer interventions. And this is what I'll show in the next few slides. So these are stylized analyses that we did for the Lancet Commission on Cancer and Health Systems that Bev mentioned. And so for these next few slides, I want you to imagine a hypothetical low-income African country with kind of typical demography, typical sort of economic situation, typical cancer epidemiology. What we did is we developed dynamic population models for the top 16 cancers by burden that are integrated within one overarching demographic projection model so that we don't double count deaths and things like that. And in doing these, we were able to estimate the cost and consequences of different interventions for those cancers and compare them side by side. Now, For the purpose of this stylized example, we just look at 16 interventions, one for each cancer. And those 16 interventions are basically a bundle of basic treatment, which would involve surgery, chemotherapy, and radiotherapy as needed for kind of typical case of cancer. So we use very average costs and average effects across the whole landscape of cancer, and just look at that, treatment of cervical cancer, for example, as one intervention. Again, this is just showing hypotheticals, so we don't go very far into which specific drugs and things, but we use averages. And so we look at the effects on disease progression of each of these interventions. These are based on literature, expert opinion. We have access to some claims data from a couple of countries and have extrapolated those to different country settings using methods we developed previously. And then we have the sort of baseline scenario assumes kind of current intervention uptake or coverage and prepayment levels. And then we look at changing those over time. Those are based on assumptions because this is, again, a hypothetical example. But you're just showing the schematic of how this model works, where you have risk factors that operate on, cancer. Some cancers have precancerous states, and so, screening and early treatment would be part of that. And then when you have incidence of cancer, you have then a cost associated with that. And some of that cost is borne out of pocket. And so the out-of-pocket share of those costs is what's relevant in the extended cost effectiveness analysis approach. And of course, cancer often usually leads to death eventually. And so you capture deaths as part of the, health outcomes. And when you intervene on this cancer through treatment, you reduce progression to death, so you save lives. You also, when you increase public finance of cancer care, you reduce out-of-pocket costs, which is shown here, and that can provide more financial protection. So we do this all within a kind of typical state transition modeling approach for each of these cancers. And I'll talk first about looking about which interventions you would choose within a cancer benefit package, and then separately, how you might think about the balance between scale and financial protection and some interesting trade-offs there. So policy lever one, as it were, within the UHC cube is deciding which interventions you want to offer in a benefit package. And I'll show you an interesting analysis we did here, looking at those 16 cancer interventions. The same kind of plot that I showed from the Ethiopia paper a few minutes ago, where on the x-axis, we have deaths averted per $1 million spent on cancer care. And the y-axis, we have, cases of medical impoverishment averted per $1 million spent. And for all the limitations of medical impoverishment that Bev mentioned, it is one of the easier ones for us to calculate and use within modeling. So we stick with that here, but we acknowledge it's got its shortcomings. And so, of course, interventions that are further out on the x-axis are more cost-effective. Interventions that are more that provide more financial protection are higher up on the y-axis. And so you want to generally be in the northeast quadrant of this plot. Those are good interventions. Those are ones that are attractive on all fronts. And so, you see there are a few things out here that are really attractive on both health and financial protection. So cervical cancer, nasopharyngeal cancer, liver cancer treatment. But you see there are some interventions out here that are cost effective, even though they don't provide they provide less financial protection. So oral cancer, a couple others. I'm sorry, the colors don't show well on this slide. But you see there's some interventions you would do within a benefit package because they're cost effective, even if they don't provide a ton of financial protection. So this is stuff that you would probably also include in a package. Let's say this is your cost effectiveness threshold here. What's really interesting to me is stuff out here, which is things that provide substantial financial protection but are less cost effective. And so this would be, in this case, thyroid cancer, ovarian cancer, stomach cancer treatment. The treatments are comparatively less effective and less cost effective, at least in our analysis in this particular country, than other interventions, but they provide a lot of financial protection. So the question is, should the government be spending money on these interventions to prevent out-of-pocket costs, even if they're not providing very much in terms of health? This is really the area for deliberation, is how much of these interventions would you prioritize based on the insurance function of the health system? So I'm not here to say what to do or what not to do, but this gives a sense for how this method could be used to optimize the sorts of interventions that you can, guarantee within a cancer program, within a benefits package, a subset of a benefit package focused on cancer. Now I'll go quickly to policy levers 2 and 3, which are, thinking about scale. So how would we scale up interventions to give access to more people? And then how would you reduce out-of-pocket costs? So in the last slide I just showed, going from 0 to 100% prepayment instantaneously, what would you get in terms of financial protection? In this case, we look at the dynamics between spending money on increasing access versus spending money on reducing out-of-pocket costs, right? because the baseline for a lot of these conditions is that costs are recovered. Government can't fully pay for services, and so patients have to buy their own medicines and things like that. And so we're talking about kind of crowding out private expenditures through greater public investment, but also spending more money to provide more services to more people, building new clinics, training more doctors, and that sort of thing. So in this analysis, what I'm going to show you is looking for those. Let's take all those 16 cancers, the kitchen sink approach, just look at everything and scale up that whole package of 16 cancer interventions to 80% of the population covered and 100% prepayment. So free care, totally free care. And this is from a baseline of pretty low coverage and pretty high out-of-pocket costs. And so if we implement this over the next 25 years, what do we get? This is a plot showing this cumulative, for this country, cumulative costs to government in the status quo scenario where low coverage and high out-of-pocket costs are maintained. And this is shown in red on the primary y-axis, cumulative costs here. And on the secondary y-axis, you see the cumulative cases of poverty related to cancer. And so you see this growing over time because you're offering services to people that they're paying out of pocket, and so more and more people over time are going into poverty. Now, of course, when you scale up interventions, you have to spend more money. Government has to spend more money, both to get higher coverage and lower out-of-pocket costs. And so that's shown here by the height of this going from 75 million to 300 million or so. But also when you're spending more money and reducing out-of-pocket costs, you reduce the amount of medical impoverishment. So you see the number of cases of poverty in this example goes down from 160,000 to 80,000 or so. So reduction of about half in medical impoverishment over time. And so that you can see the dynamics of how this might change the projections of health and financial impact over time for this set of interventions. But of course, we're not just spending money, we're saving lives. And so here's a plot showing all the cancer deaths we're preventing. And so you see it's kind of a mix across all these cancers. Probably cervical cancer and breast cancer and a couple other high burden cancers are driving the results, but you get benefits across a wide range of cancers. But one thing I want to show is that you can look at how far you can go in both of these dimensions for a given budget and what you would get in return. And so what I'm not showing here is the amount of money in each of these cells, but this is basically just a bunch of scenario analyses looking for breast cancer. If you reduce from the reference being 100% out of pocket, going down to 80, 60, 40, all the way to 0, you get a reduction, you get a number of poverty cases averted. So in this case, it's 33,000 poverty cases averted, shown here in green. Also, if you scale up coverage and increase access from 0 to 10, 20, 30, 40, 50%, you get deaths averted. And so the numbers of deaths averted are shown here in the red. And so for a given combination, extra 10% coverage, 20% reduction in out-of-pocket costs, you could save about 47,000 lives and prevent about 4,000 cases of medical impoverishment. Whereas all the way out here, if you provided everything to half the population for free, you could save a lot more lives and provide a lot more poverty cases. But, maybe not all countries could afford to do this. And so this gives you a sense about where along the spectrum you could try to optimize on both health and financial protection outcomes for this particular cancer. A couple of future directions for extended CEA for cancer. One is that what I showed you the last few slides does not look at equity at all. It just looks at financial protection and health. The challenge with looking at equity in cancer is that there's not a lot of great data on the distribution of cancer risk and outcomes across population groups. But this is a hypothetical example, again, looking at intervention across 5 wealth quintiles from the poorest to the richest. And on the y-axis here, we have the number of catastrophic health expenditure cases. Now we've flipped and switched to another metric. But what you see here is that, the visualization is that, you're getting... For different scenarios, you can look at the impact of different scenarios on the incidence of catastrophic spending. And as you might expect, the wealthiest in the population are not really getting any financial protection because they can afford services already. But the poorest are the ones who are really sensitive to changes in scenarios. And so if this is a baseline scenario where you keep coverage the same and if out-of-pocket costs stay the same, then you have 280 out of per 1,000 people basically going into poverty. If you just increase coverage, but you don't reduce out-of-pocket cost very much, you're actually creating poverty. And this is an important lesson, which is that if you expand services but don't have a plan to cover recurrent costs, you still actually end up creating more problems. And so for the poorest, you still have some, even with very low out-of-pocket costs, you still have some catastrophic expenditure, but that goes down pretty rapidly for the other quintiles. So looking at this, the point of this is not an actual example of a cancer policy, but looking at different quintiles can give you a sense about the distribution of benefits in different scenarios. So this is work that we'd like to do more in cancer, but we really want to focus on getting more data related to different population distribution of health and economic outcomes in some countries. The other thing we want to do pretty soon with the modeling tool is put it online for people to use and do scenario analyses around cancer programs. So if you're working in Uganda and you want to, optimize your cancer program and think about cost and think about which services to prioritize, this would be a digital tool to allow you to do that, upload your data and do some modeling based on the work that we've done and get impact. So this is just some screenshots from a tool we developed on NCDs, not on cancer specifically, but kind of basic NCD care. So you could think about, selecting your interventions and kind of editing effect sizes, inputting different costs if you disagree with our default inputs, getting some outputs around like cost effectiveness ratios for different interventions under different sort of scale up scenarios. And then looking at some dynamic outputs of your analysis. And this would allow you to kind of get some insights into your cancer program that you could iterate on with technical experts and say, okay, we're spending too much this time. Let's go back and change this or that. So this modeling tool would allow governments and policymakers and development partners even to think about their investments and optimizing their investments around health and again, around financial protection and other measures. So this is stuff we'd like to do in the near future based on the modeling work, and hopefully some countries would find it useful too. I'll stop there and just rehash a couple of key messages. First, as has been said a few times already, making progress on universal health coverage in the area of cancer does require a careful design of health benefits packages. We think that extended cost effectiveness analysis really informs the UHC conversation more effectively than conventional CEA by explicitly thinking about financial protection and equity alongside value for money. But as I showed in a couple of those slides, there are important trade-offs between health and financial protection, especially for cancer. And this might inform how you design co-payments for services and which sorts of services you prioritize. And it might actually lead you to different conclusions that you would get just by looking at cost effectiveness. And finally, for the Lancet Commission on Cancer and Health Systems, which we're working on finalizing that commission now, this background work that I showed you is going to include some digital tools, I hope. And so would love to continue to share those results with people and partner to test this work out in countries that you're working in. Thanks very much for your time.
Thank you, Dr. Watkins, for a very comprehensive explanation of the extended cost-effective analysis, particularly how we can integrate financial risk protection into the cost-effective analysis and how it can potentially change how we prioritize health interventions. So I'd like to invite Mr. Yoshida for very efficient comment.
Yes, okay, thank you very much. Yeah, I'm Tomoya Yoshida from JICA headquarters, Human Development Department. And first of all, I'd like to thank all the presentators for your informative presentations. And we have 3 valuable presentations on the challenges of cancer in low and middle-income countries. JICA has not yet implemented many cancer-focused projects. This is partly because JICA's projects are based on the request from counterpart government. So there has not been much cooperation in this area so far, but as Dr. Ida presented, the impact of cancer is increasing in low and middle-income countries. And I think there will be more and more requests for JICA's cooperation for cancer. So one of the main pillars of JICA's strategy is health sector is to improve healthcare infrastructure and health human resources to strengthen health system for better service deliveries, including cancer. For example, in Vietnam and Kyrgyz Republic, we have assisted mainly facilities and equipment of their cancer hospitals for diagnosis and treatment of cancer. And we also providing technical training for Palestine and Moldovans and other countries, healthcare workers on cancer in Japan. So supporting facilities and human resources is important, but ensuring access to service, especially removing financial barriers, is also important issues. In today's presentation, the importance of appropriately positioning cancer-related services as a part of the health finance system was also mentioned. And strengthening health financing is also an important part of JICA strategy, and I felt that the perspective presented today need to be incorporated in our strategy as well. So JICA believes that cancer-related effort will become more and more important, and keeping in mind the perspectives presented today by both the presentators, we will continue to work with our counterpart government and development partners to improve the access to necessary services for cancer patients in low and middle-income countries. Thank you very much. Is this short enough?
Thank you very much. So the time is running out, but I'd like to ask all the presenters to pick up some of the questions coming through the Q&A box, and then try to provide a very short and crisp response to some of the questions, even though some of the questions are already answered through the box. So I picked up some of the questions coming online. One is the example of effective policy response to reduce financial burden from the cancer care. And then something related to that, how about the importance of prevention and early detection and management? Another one is the challenge of limited public finance, how the government can finance those services. And then also another question is about the long-term sustainability for the government to doing that. And then finally, probably the role of international cooperation and partnership. So if you can pick some of the questions which you think is relevant and try to respond, it will be appreciated. Maybe I can start the order in the order of presentation, starting from Dr. Ida.
Thank you, Mr. Takizawa. Because my internet connection is not with, maybe I should turn off my video. I picked the last question on the role of international aid and multilateral partnerships. So I also answered through my chat box. But I believe, first of all, we need to shift our thinking and start including cancer as part of our global health discussions. I think that is the first thing. And in order to do that, I think international aid agencies and our friends in the community can take into consideration, based on the evidence, that this is one of the important issues. So that is, start talking about it is one thing. And also finding, well, eventually we have to provide support, but how, well, I think depending on the country, but maybe through the health system strengthening efforts. We talked about UHC a lot today, and the aid community has been focusing on UHC efforts. So since cancer is a major impoverishing factor in today's low and middle income countries, this should be part of the program. So that is one thing. Concretely, I believe there's a serious lack of evidence on this topic in poor countries. So research, implementation research, and also academic research should be funded so that health policy can be made and the assistance can be made based on such evidence. I wrote in my chat box that many countries lack national strategies to tackle cancer. Unfortunately, for instance, in Burkina Faso, where I have been conducting my research, cancer strategy has not been approved due to the lack of funding. I think there need to be some basic infrastructure to even to talk about cancer as part of global health, and I think such area can get more attention. I also think that existing efforts we can work with existing programs so that cancer can be included. Some cancer can be detected early at the community level if health workers can be trained to identify symptoms. For instance, childhood cancers some of them can be easily detected by health community level health workers. And I think this does not require money, but such, how can I say, interventions that do not require huge investment but can create a lot of impact can be prioritized, and aid community can start working on. Thank you.
Thank you, Dr. Essue.
So I'll just add a little bit more because I think that was a very comprehensive response and covered a lot of the areas I was going to touch on. I would further emphasize the importance of the cancer plans. While there's probably over 100 countries now have a cancer plan, almost none have budgeted them. And so this idea of taking the plan forward to think through how we will invest in such a way to achieve the goals of the plan, I think the prioritization and the stated commitment is there in the plan, and starting to think through how the shift in the health system budget moves towards supporting that plan is an important next step. And I think a lot of the work that David presented is a way forward in being able to present that at a national level to be able to support some of those decisions. I think that links to one of the other questions that was raised, I think directed to me, around how do we, on the one hand, expand services and make a case for expanding services while also advocating for also managing and controlling catastrophic health expenditure. And so quite an important point here is that the expansion of the services to address cancer really need to be done in the context of a prepaid national program where the cost sharing requirement for those services is managed. And obviously the fiscal space to be able to do that, we have to be mindful of that. And so it's not doing everything all at once. It's thinking about what the opportunities are to invest and expand in a progressive way. The last thing I want to say is part of this mindset shift with cancer is required because there's such a heavy emphasis on thinking about the most costly things, the new innovations, the new drugs that are coming through, when the health workforce requirements for cancer provide a lot of opportunities to think about new models to be able to address cancer in innovative ways. And so that mindset shift will support investment in different ways. So.
Thank you very much.
So many great things have been said, so I'll be brief. 2 points. One, I think that, some of the comments of the chat, we as people who work in cancer need to think about working together with other people in health, because health has just fallen off the priority for many governments. And if we all work together, I believe that a rising tide lifts all boats. Increasing health spending isn't a zero-sum game. And so if we all advocate for more money for health, that will eventually benefit cancer and other conditions as well. And so that's, I think, the path to sustainable financing is getting health to be a priority for governments. And that's a big enough agenda in itself. And the second thing I would say is that it is important to think about palliative care as part of this conversation, because not every cancer intervention is effective or cost effective. And without building a foundation of palliative care for individuals, you're going to have people seeking very cost and effective care and paying a lot out of pocket. So one of the advantages of palliative care is that it crowds out less cost effective out of pocket spending. And so if you have an option to relieve pain and suffering at low cost, then families don't feel forced to, pay money for expensive treatments that aren't working very well either. So I think this conversation is not just about treatment, it's all about palliation and care of the whole patient, the whole person. And just one more thing that I remembered, there's some comments in the chat about cancer costs and cancer drug prices. And I think this is a collective action issue that organizations like JICA could support more. How do we think about working together to bring down cost of cancer therapies across countries? How do we pool our resources together to get more efficiency in purchasing? I think that's something that could benefit lots of countries at the same time. Thanks.
Thank you very much. The importance of market shaping and the importance of working together. So I think the time is running out. I really appreciate the great presenters as well as the commentator, and also the active participation of all the participants. Thank you very much. We have a lot of great seminars coming up, so stay tuned. Thank you very much.